Okay, I have two questions about left-handed individuals, going through TMS, and one about insurance, the other one about like what do we do in this case. Okay, so I'm gonna read the first one, answer it, and then we'll go to the next one because I think the answer is gonna feed into each other. So what if a left-handed patient goes for a full course of TMS treatment covered by insurance where the doctor used high-frequency stimulation to the left DLPFC, but the patient does not respond positively? Then the patient goes to a new doctor, pays out of pocket. That new doctor is willing to try a different protocol such as high frequency to the right DLPFC for a couple of sessions, and the patient responds positively. Is insurance likely to approve further treatment using the changed protocol since the patient has shown positive response during those out-of-pocket sessions? If so, is there a certain level of response required? Okay, well, the first part about this is that the patient, finished the first course of treatment on the left DLPFC and there was no response. Maybe in the middle of the treatment when there is no response, that's when the first doctor should have made some changes and considered, whether laterality of treatment is a component of it or not. But anyways, we continued through the treatment, and then the person said, I, went to a second doctor. They did a couple of treatments on the right side, and the patient showed response. That is useless response. This is placebo. TMS is not going to be helpful in one session or two sessions. Go to there is a video that I made about TMS dip and the explanation of why this could happen and what have you, and that feeds into one of the very first videos that I made about when do you see a response. A response, a separation between sham and active shows in the second week of treatment, and most responders respond by the fourth week of treatment. So if I was the one who's reviewing the case from insurances and that doctor told me, oh, this patient is doing great, I did 2 sessions on the right side and she's doing really well, I want you to approve 30. Like, if 2 sessions are doing the tricks, then why do you want 30? It doesn't make sense, from the neurophysiological standpoint. We need consistency until we have a meaningful change that happens in the brain. But let's say that this is the case, then what do you do insurance-wise? You're going to submit for a new approval for TMS. They're going to review the case. They're going to deny it because the patient did not respond to a previous TMS course in the past. The office manager is going to ask for peer-to-peer. The doctor is going to kind of get involved in that peer-to-peer, and they're going to explain their case to the other doctor, from the insurance point of view. If it was Optum or Aetna, good luck. They're not going to say yes, and they're going to take it all the way, to denying as much as they could. If it's Cigna or maybe Blue Cross Blue Shield, sometimes you get a reasonable person. The doctor could explain the situation. If they're convinced, then they could approve certain number of treatment sessions to see how that goes over time, and then if there's still positivity, then they can approve it beyond. I apologize, I misspelled the word patient in here, but regardless of any of this, the patient themselves, they can actually appeal a denial. When a patient appeals a denial, insurances would actually listen, unlike when doctors appeal a denial, right? Because there is a conflict of interest for a doctor to say, hey, I disagree with you. Well, of course, because you want to treat another patient, right? But if the patient says, you know what, I disagree with you guys, I really need this treatment, and this is the only thing that is helping in my case, then insurances usually would listen to that. So if you're that motivated to kind of go this route, then just appeal the decision. All right. Now, the same question about not insurance in this situation, it's more about right-sided and left-sided, comes from another person. And the question asks, do you use different protocol for left-handed patients than right-handed patients with depression? And how do you determine if a patient is being stimulated on the wrong side versus just poor/negative response to TMS? Okay, all right, so you know now why I kind of connected those two questions to each other. Because that first question, the clinic, if they were re-evaluating the patient, regularly throughout their treatment, in the middle of the treatment, they're going to notice, hey, there is no improvement. We might need to re-evaluate the laterality of where the patient is right-handed or left-handed. Okay, so a little bit of a joke in here. It seems like every left-handed person thinks that they're special, right? And they always want to, they are special. A lot of left-handed people are very talented and artistic. But that's my best attempt at a joke, so I apologize. All right, so we have to distinguish between the right-handed, left-handed dominance in the brain, speech dominance, and DLPFC dominance. Okay, I know I confused you a little bit. In your motor cortex, you could be, or most people are left hemisphere dominant, meaning that they're right-handed, okay? So there's a cross between the two, all right? Okay. Now, there are patients who are right-handed, left hemisphere dominant, right? That their speech area is also on the left hemisphere. So if they have a stroke or something, on the left side, then that would affect their speech and what have you. Now, sometimes that speech area, or not sometimes, most of the times that speech dominance is correlated with the motor dominance, right? Of where are we right or left, okay? Most of the times. Sometimes it's not correlated. Okay, what does that mean? The majority of patients who are left-handed, right, despite that your motor cortex is like more mature on the outside, that is kind of you performing more tasks with your left hand, your speech dominance is still on the left side, right? So you're left-handed motor-wise, but your speech dominance is still left hemisphere. That the majority of left-handed patients, okay? All right, so the fact that you write with your left hand does not mean that the doctor has to change the location of your treatment from the left DLPFC to the right DLPFC with an activation, right? Obviously, with inhibitory pulse is a different situation. All right, now there's a third thing. That thing about speech might not correlate with the DLPFC, which side has better control over our limbic system, that controls your depression and what have you and stuff like that. So far, from what I've been reviewing from the functional connectivity MRI anti-correlation between the left DLPFC and deeper structure of the brain, they do not really care about whether the patient is right-handed or left-handed, right? And we still think that the left DLPFC is the one that is responsible for the with the strongest anti-correlation with the ACC, is the one that's responsible for depression. Okay, all right. Now that being said, that doesn't mean individually you don't pay attention to that. So if a patient who's left-handed, we still think that majority of left-handed patients are still left hemisphere dominant. So we went with the treatment with the left-sided, high frequency TMS, and then, after 10 sessions, 15 sessions, there is no improvement in that patient, and we want to review whether we want to kind of put the treatment call on the other side or not. Yeah, you can do that. That being said, there is a way or a trick that some neuroscientists use to kind of decide whether somebody is left dominant or right dominant, which is speech arrest. Okay, what is speech arrest? You could use, remember in one of the videos that we did about low frequency TMS and theta pulse stimulation for anxiety, look at previous videos to kind of see that. I explained then that if we continue delivering a pulse consistently without any breaks, that is inhibitory to the brain, okay? So that means if we use continuous theta pulse stimulation on the area of the brain that is related to our speech, Broca area, where we actually make speech, if we deliver that stimulation continuously without any interruption, that will cause inhibition of that area. And then the patient will have speech arrest. They cannot say things anymore, okay? So if we do that on the left side and we confirm that this is the left hemisphere dominant, if that doesn't happen on the left side, then we can do it on the right side until the patient cannot say things anymore or they miss their speech, then we confirm that they're right hemisphere dominant. But again, that's for their speech. Could be related to their DLPFC or not, okay? Right, so basically, for left-handed patients, we still go with the left hemisphere high frequency. If that doesn't work out, then we review what we want to do. We could confirm the hemisphere dominance by doing something called speech arrest to kind of see which hemisphere is more dominant for that person. That may or may not correlate with the DLPFC dominance. Speech dominance may or may not correlate with the DLPFC dominance. Okay, all right. Hopefully this answers your question. Disclaimer: although I am a psychiatrist, this is not a professional advice as I am not familiar with the specifics of your unique situation. Please contact a psychiatrist in your area with more questions. This disclaimer is added to my answers on social media after consulting with American Psychiatric Association. Thank you.